Good morning. I'm Hayden Bush with the AHA's Hospitals in Pursuit of Excellence platform, and I'm here today with Dr. David Pryor, Chief Medical Officer for Ascension Health. And we're here to discuss some of the quality initiatives ongoing at Ascension, and I'd like to start by telling us a little bit about Ascension Health's quality direction.
Well, Ascension Health's quality direction has been important since the organization was formed 10 years ago. Originally, it was one of the 5 distinguishing characteristics, clinical excellence. And then in 2002, we set the strategic direction for the organization with the statement, "Together we promise healthcare that works, healthcare that's safe, and healthcare that leaves no one behind." The healthcare that's safe strategy was defined as excellent clinical care with no preventable injuries or deaths by July 2008. And that really formed the focus of the work for that period, that 5-year period between 2003 and 2008. More recently now, we've gone on to a direction that we refer to as healing without harm by 2014.
And can you tell me a little bit about kind of how the projects have evolved and kind of where healing without harm is evolving to?
Well, the original work that was excellent clinical care with no preventable injuries or deaths by July 2008, we set up really as a strategy to first define what that goal should be. And we decided that there were 900 lives that were potentially savable, 900 lives a year that could be saved in our system. And we calculated that by going back and referring to the original 2 studies that had been cited in the Institute of Medicine report that said 44 to 96,000 lives a year could be saved. And when we applied those numbers to our system, we thought that about 15% of those patients not admitted for end-of-life care who were dying, that could be saved, and that translated into 900 lives a year. We then approached the work by trying to understand how would we attack the problem. And we brought together a rapid design planning team of about 40 individuals, plus our strategic partners from the Institute for Healthcare Improvement, including Don Berwick. And we identified what we referred to as 8 priorities for action. The 8 priorities for action included mortality itself, the Joint Commission National Patient Safety Goals, adverse drug events, nosocomial or hospital-acquired infections, surgical complications, falls and fall injuries, pressure ulcers, and birth trauma. And then we had strategies where each one of our organizations provided. One of our organizations, we call our hospitals ministries, one of our ministries provided leadership for the initiatives within our system. In some cases, 2 or 3 would take the leadership role. And that strategy created affinity groups across our system where we shared the lessons learned. And to make a long story short, the strategy was remarkably successful. Today, the numbers would tell you that the number of lives being saved, adjusted for severity of illness in our organization, is well over 4,500 per year, and the number of lives saved, even without looking at any adjustment for increasing severity of illness, is over 1,500. So we more than doubled or quadrupled the original goal. The goal that we're working on now, healing without harm by 2014, recognizes the fact that a lot of our work really plateaued. The improvement really plateaued in each of those individual priorities for action, as well as if you look at our overall mortality statistics, what they would show you is that the raw or the observed mortality rates have leveled off in our organization after declining significantly. And so the strategy that we're using to move forward now, rather than trying to focus on an individual disease element or process like birth trauma or falls or fall injuries or nosocomial infections, instead gets at the very fabric of how we work together as an organization providing care. And in that construct, we have committed ourselves to becoming a high reliability organization. Mm-hmm. We are borrowing lessons that have been learned from nuclear power, from the manufacturing industry, from other approaches, to develop strategies that enable us to understand in detail not only why individual events might occur, but then how do you prevent those events in the way we work together. Because we are all human, we all make mistakes. But it does not mean that the mistakes we make as individuals have to impact negatively on a patient. If we work together in the right way, it can enable us to make sure that the mistakes that we make as individuals don't cause harm to a patient.
And what are some of the high reliability principles that you've been able to put in place so far?
Well, the high reliability principles have been articulated by a number of others, not by me, but if you look at Wick and Sutcliffe, they'll talk about several principles of anticipation and principles of resilience or response in an organization. But essentially, high reliability means that you're able to do what you intend to do, and you do it every time that way. In this country, you can't build a nuclear power plant until you're able to demonstrate 10 to the minus 6 reliability, 1 in a million. If you look at healthcare overall delivers probably somewhere between 1 in 100 or 1 in 1,000 at an overall error rate. That's just simply not acceptable in terms of the quality of care, but it does require that we have to become preoccupied with safety, that safety has to become a cultural focus for the organization. There needs to be the right balance, as James Reason would say, between protection and production within an organization, and what enables us to provide consistently high quality care all the time. What we find in practice is that as we've done this work, it means we train every individual in our organization, as well as every individual who works there. So for us, that's a commitment to train 140,000 people. It's a big commitment across our organization. And it changes the way we all work, and it changes the job, in a sense, of everyone who works in the organization. We become preoccupied with safety. And it enables us to work together in a way that really does provide a higher quality of care for individual patients, makes it much less likely an event will occur. So that we have seen an astounding reaction now, particularly among our physicians who really believe that this work is important and have really engaged. In one case, in one of our organizations, the medical staff voted voluntarily to pay for part of the initiative out of their medical staff dues. And so I've really seen it in a way that I've not seen before capture really the hearts and minds of all the caregivers across our organization.
And how does that effort permeate to the other aspects of the operation? So how do you view quality connecting to the financial picture of Ascension?
Well, that's an interesting question, and that's a question that has been raised by many for a long time. And the truth is probably that we really don't have the kind of convincing and compelling data that would enable us to respond that the relationship between quality and operational performance is absolutely clear and unquestionable. And so I think it sort of separates the world into two groups, those who believe that it does and those who don't. Every other industry that's ever studied this has demonstrated that in fact they are related. We've seen the bondholders and some of the other bond rating organizations begin to start talking about the importance of quality and cost. We can show examples of dramatic decreases in our overall malpractice liability and other programs in terms of cost. We can show cost improvements in specific areas. But really the overall question has to be one where you believe that, as Deming would say, quality is free. It doesn't cost you anything. By eliminating the costs of rework, the costs of poor quality, in fact, an organization can improve their quality in that way.
And do you see this as something that more organizations will embrace in the changed healthcare landscape?
Yes, we're not the first. We're picking up strategies that Centaur originally developed with some consultants that had a great deal of experience with other industries, and I expect that this probably will grow. I think the key element for a specific organization is, depending upon where you are on your quality journey, probably dictates the best strategy for how you should move forward. There's not a specific approach that is always going to be the best for any organization. This principle, in fact, relates to work that Amilberti and others have done in terms of talking about, depending upon where you are, different strategies are required to now raise that bar and improve still further. We believe that it was important for us to address and get at the first issues around the basic high-risk processes across our organization. Those areas that we could attack directly and begin to work in that way. And we estimated that 900 lives could be saved, and the number is far larger. When we do our work now, we think the impact on mortality is more likely to be about 350 lives. So that it's again, one order of magnitude improvement, if you will.
And is that sort of the next step in this process in terms of re-engineering some of your facilities?
Yeah, I think it's likely to be. We're working on that now, and to my knowledge, this has really not been done. There have been some groups that have piloted some of this work, and I think the VA did some work in some of these kinds of areas. But we're approaching the strategy from taking a very specific and detailed approach for analyzing every inappropriate act of every serious safety event that occurs, near miss and precursor event. And what that does is then give us an opportunity to create an information base that will provide us a quantitative view into where the opportunities really are, as we then can begin to apply some engineering principles to understand how we would re-engineer, if you will, that environment to create a much more highly reliable system. The errors that occur as we provide care, or inappropriate acts from individuals, occur for a whole host of reasons, some of which are related to the environment in which they're working, the technology, how it works, and the other approaches. And it's a fruitful area, I believe, for us to be able to take on and ensure a higher standard of care that we provide for the patients we serve.
Mm-hmm. And finally, I'm just interested in kind of how you see Ascension in terms of this culture of safety, say 10 years down the line, in terms of where you're hoping to be in terms of some of your initiatives.
Well, I think this gets back a little bit at the operational performance question that you asked before. An organization that is able to deliver high reliability health care means that it's really able to execute and deliver reliably in anything it does. And what we're seeing is what might be called a spillover, or an effect that we're seeing in a lot of the initiatives we work, where as we understand how we work together to improve quality and safety, then the other dimensions of quality become important: efficiency, eliminating waste, other approaches for how we work together to maximize the quality of care we provide, and to do it with resources that are appropriate in the particular environment. So we are seeing that kind of impact, and I think it just is going to become part of the way we do business, the way we provide care.
Well, thank you so much for joining us, and good luck today.
Thank you.